This is Dr. Nikravan, Endocrinology and Metabolism. Welcome to the lecture series. My goal is to bring awareness and alertness to a subject which is very widely common. During each subject, I may ask questions that will be quiz questions, so therefore I want your full undivided attention, so therefore we can make sure we walk away with lots of knowledge and education which you can share with your friends, family, and have a lot of tools in your own basket. The topic of the lecture series today is perimenopause going into menopause. The clinical features of perimenopause is very much a classic of diagnosis. We make the diagnosis not through laboratory testing, but through a clinical diagnosis. What that means is we make the diagnosis through listening to the patient and listening to their history, and that pretty much gives our diagnosis. These symptoms are typically associated with increased length of menstrual cycles. These cycles, if someone has a normal cycle between 28 to 30 days on the clock, these patients typically have a longer menstrual cycle length. They could now turn to 30 to 35 days or even longer. And sometimes the cycle between their bleed cycles also changes. Therefore, when you obtain the history on these patients, it is crucial to understand how their cycle was before. It could be a bit difficult if the patient is on birth control pills to begin with, but we'll talk about that a bit later. These patients typically complain of also possibly hot flushes in the very early state. As the patient progresses from perimenopause early state to late state, they happen to have more robust hot flushes. When they check their laboratory data, you find out the FSH level, which is a signal that comes from the pituitary called follicular stimulating hormone, FSH. These values may be mildly elevated, but when you check their estrogen levels, you find out estrogen levels are normal or even high. And that's because it's compensating by increasing more estrogen from the residual ovaries as they're slowly dying out. Over time, these symptoms become more severe, which leads to sleep disturbance, which is known as hot flushes, vasomotor symptoms, progressive to vaginal dryness, mood changes, and then cycle changes become prolonged. And therefore, that's how you get the clinical diagnosis, by listening to the history and the patient's cycle. So it's very important you have a very thorough history in understanding these patients when making this diagnosis. When you're about to confirm a diagnosis of menopause, you typically need 12 months of no menstrual cycle. That is considered the final menstrual period, FMP. Therefore, if the patient has a cycle once every couple of months, that means there's still residual ovarian function, and that patient has not gone on to menopause. So you need 12 months of no menstrual cycles to be able to have the diagnosis of menopause. The most common symptoms of perimenopause to menopause is vasomotor symptoms, which is known as hot flushes. 80% of women who go into menopause complain of vasomotor symptoms of hot flushes. These symptoms can be very severe because they can really affect a patient's day-to-day function. And also, the loss of estrogen, progressive decrease of estrogen, also leads to genital uretary symptoms. That means that the vaginal mucosa, which has once been fed by estrogen, has now decreased in estrogen, therefore decrease in vaginal lubrication, dryness, itching, and also increased risk of urinary tract infection. These are two very, very common things we see in patients who go from early perimenopause to late perimenopause into menopause. How is a diagnosis of perimenopause made? So my question is, number one, this is a clinical diagnosis, not a laboratory diagnosis. And patients are ranging between the age of 45 to 50. It's probable they're going through perimenopause to menopausal changes. If these symptoms happen between the age of 40 to 45, that's a bit early, but still can happen. Therefore, in these subset of patients, you need to have an endocrine workup. That endocrine workup talks about other possible metabolism that deals with their menstrual cycles. For example, they need to have their thyroid checked. Number two, they need to make sure they're not pregnant, of course, and have a laboratory test called prolactin. It's a pituitary hormone, comes from the anterior pituitary. These are very important to look at the endocrine system to make sure there are no secondary causes that's causing a delayed menstrual cycle or prolongation or absent menstrual cycle. Very important topic. Once a patient hits the age of 45 and above, it is more probable they're going through perimenopausal changes. unless this patient presents with other symptoms of night sweats and night fevers, and you have other abnormal findings, which then you need to take a look very carefully to see, are there secondary causes for these night sweats, which mainly they're going to be perimenopause, menopausal hot flushes, vasomotor symptoms. Of course, you want to make sure you don't miss other malignancies. Therefore, a careful evaluation is necessary if the case is not making too much sense. In women who are under the age of 40 who stop having a menstrual cycle, that is very uncommon. But when you see those cases, you need to start thinking of possibly ovarian failure. Therefore, a workup needs to be evaluated by looking at these patients carefully. In those patients, you will have a very low estrogen level and a high FSH level out of proportion to their menstrual cycle and their age, which needs to be taken a look at, which is part of the endocrine workup. As patients progress through the early perimenopause to late perimenopause, typically what happens is the menstrual cycles goes from every 25 to 28 to 30 days to 35 to 40 to 50 days. And the cycle bleed between these cycles also increases. During this time, there is a serum hormone called inhibin B, which also decreases, which looks at the ovarian function. Last but not least, you have progressive increased elevation of a hormone, biochemical signal, FSH, follicular stimulating hormone, which comes from the pituitary. That is a negative feedback which is no longer inhibited based on low estradiol level. So the key concept is in early perimenopause versus late perimenopause. In early perimenopause, you have a normal estrogen, maybe even a high estrogen, but a mildly elevated FSH. In a late perimenopause, you have a significantly higher FSH level, and this time either a normal to a much lower estradiol level. And that's how you can determine what state that is. But then again, it's based on history and the patient's age. So if they're more closer to 49 and 50, they're probably more in the late perimenopause phase. The number one hallmark of menopause or late perimenopause is hot flushes. 80% of women have hot flushes, and the hot flushes can be very much disabling for many reasons. As the patient goes from the early perimenopause to the late perimenopause period, their cycle length progresses and becomes longer and longer. Hot flushes are very much characteristics of sensation of heat that starts from the chest area, the neck, or sometimes the face, and it dissipates to the rest of the body as generalized sensation. Then this follows with perspiration, feeling of chills, anxiety, and nervousness. These symptoms typically last between 2 to 4 minutes plus or minus. The symptoms can be quite debilitating because those hot flushes disturb the patient throughout the day, but mainly occur morely at night. When they occur at night, they disturb the most important, precious thing in our life, which is sleep. The loss of circadian sleep cycles, loss of REM and deep sleep significantly affect the patient's energy the following day, and it becomes a cumulative effect over time. Therefore, you need to understand if this patient has a very mild symptoms of these vasomotor symptoms or moderate to severe. And those patients who have moderate to severe dysfunction with these symptoms, these patients should be taken very seriously and should be treated accordingly, because the loss of this hormone and dysfunction creates substantial problems for their day-to-day life. The question we get quite often is, how long do these vasomotor symptoms last? They typically start right around the late perimenopausal phases, and they go into menopause, and they usually last for a few years. Although some patients have the unfortunate luck of lasting somewhere between 10 to 20 years. Therefore, those patients should be taken very seriously to be treated accordingly. The biggest problem in these hot flushes that occur in patients is loss of sleep. The loss of sleep is significant, debilitating to patients because they can't function at work, they start losing their jobs, their mood changes, their fatigue becomes so severe they can't function day to day, especially if they're dealing with children, or if they're busy professional moms, or even if they're moms at home taking care of a home, which is very heavy work. Therefore, they're just exhausted constantly, and this exhaustion plays into a mood, and this mood eventually leads to possible depression. Depression and anxiety is definitely exacerbated, brought on by this hormone loss. The studies have shown that patients who have a propensity to depression and anxiety have severe exacerbation of the baseline anxiety and depression once they go through the perimenopause, menopausal changes. Therefore, these patients should be on therapy, especially for the dysfunction that it creates and the sleep deprivation. As we know, the sleep deprivation is the biggest problem. These patients lose the ability to get REM sleep, which is restorative sleep and deep sleep. That's because as soon as they fall asleep, they wake up with these hot flushes and they go in a state of panic with feeling of heat sensation, chills, and perspiration, and all of a sudden palpitations, which can be catastrophic at night, not allowing them to sleep at night. Therefore, we should take these patients very seriously. Some of the biggest changes patients have during the perimenopause, menopausal years is also bone loss. We do know that estrogen is quite beneficial for the health of the bone as it helps build bone. Yes, estrogen is very important for healthy bones. But more importantly, there is a lot of data showing cognitive defect in patients who have loss of estrogen. Their mood changes, their anxiety, depression can really be brought upon by a loss of estrogen. Other common symptoms are genitourinary symptoms. Genitourinary symptoms is secondary to decrease in loss of estrogen. Yes, estrogen is necessary for the vaginal health, and the vaginal health really depends on estrogen for the blood supply. Therefore, lubrication, vaginal health, vaginal wall thickness is very important. As you lose estrogen, your vaginal wall becomes thinner, the lubrication becomes less. Therefore, it becomes more painful during intercourse. That's why vaginal estrogens are recommended in those patients who postmenopausal or lubricants in that aspect of it too. These same patients have problems with increased risk of urinary tract infection because estrogen is responsible for the health of the urethra, which connects the bladder to the vaginal opening, which is urethral meatus. And that shortens, the shortening of the urethra in that region creates increased risk of bacteria and urinary tract infection. So as you can see, estrogen has a huge role in the management of these patients who are symptomatic. The long-term consequence of estrogen loss has negative effects on the bone because estrogen is needed to make bone. We have bone-forming cells, which are dependent on estrogen or testosterone in case of a male, and they have bone-destroying cells, which is the remodeling of the bone process because we make and remodel bone on a daily basis. The other aspect of it is understood that estrogen is responsible for a decrease in bad cholesterol, lipo-LDL. That's very important. Also an increase in HDL, which is the good cholesterol. So theoretically, if you lower the LDL, increase the HDL, you should have less cardiovascular outcome. These data are a bit sketchy, but that's the theory behind the lipid benefits. And last but not least, cognitive benefits. It is believed that estrogen sits on the central nervous system by feeling of vitality and health. Therefore, loss of estrogen allows the patients to feel more down and depressed, which is something to be taken very seriously. We see this complaint quite often. As women get older and they lose estrogen, especially if they go the perimenopausal to menopause years, there's a lot of skin changes. And these skin changes are derived from the loss of estrogen because estrogen has a very positive effect on the fibrous tissue known as collagen, which gives the skin the nice elasticity and the filling of the skin. So again, there are definitely effects on the skin that we see in patients. In women who are taking contraceptive pills, birth control pills, all the way to the perimenopause, menopausal state, it is very difficult to understand if they have gone into the perimenopause or menopause because birth control pills are very high dose estrogen, much higher than the body makes. This suppresses the hypothalamic pituitary axis by sending signals to the ovary. Therefore, you have a low FSH there. At that point, we encourage patients to discontinue birth control pills and test their labs approximately 2 to 4 weeks after cessation, and we get to see exactly how high their FSH values go and what happens to LH values. In these patients who then suffer from menopausal changes, hot flushes, these patients may be a good candidate for hormone replacement therapy if there are no contraindications. In patients who have undergone hysterectomy or uterine ablation early in the years, in their menstrual reproductive years, it is very difficult again to understand have they gone through menopause or not because these patients are typically on hormone replacement therapy, either on estradiol and progesterone because they lost their ability to make estrogen and progesterone very early on. Therefore, in these patients, the first thing you do as you decrease the hormone values, you'll see a rise in FSH and LH values and menopausal symptoms that take place. Therefore, hysterectomy, uterine ablation patients, you can't depend on the menstrual bleeding because these patients don't have a menstrual bleeding cycle for you. Therefore, it's biochemical changes and laboratory testing necessary for these patients.